Welcome to Roadmap to Residency. Hello everyone, I am Aviraz. Welcome to our Club 250 Matchmaker sessions. We will be running through a few questions with you guys to help you on your journey to a 250. So whenever you encounter USMLE style question, the first thing you need to do is to read the last line first. So what microvascular complications of diabetes mellitus are most likely affecting this patient? A 60-year-old male with a long-standing history of poorly controlled type 2 diabetes mellitus presents for his annual checkup. He reports experiencing worsening vision and frequent urination at night. Ophthalmologic examination reveals microaneurysms, retinal hemorrhages, and heart exudates. Urine analysis demonstrates the presence of albuminuria. Now, what microvascular complications of diabetes mellitus are most likely affecting this patient? Diabetic neuropathy and diabetic foot ulcers, diabetic retinopathy and diabetic nephropathy, diabetic ketoacidosis and hyperosmolar hyperglycemic state, diabetic gastroparesis and erectile dysfunction, diabetic ketoacidosis and diabetic retinopathy. Now, these all options are the complications of diabetes mellitus now and then. Okay. So this is a very easy question, a very straightforward question. I'm putting this question only to make you guys oriented because why we are going to discuss about the complications of the diabetes mellitus in this video. So the patient's clinical presentation is indicative of two common microvascular complications, that is diabetic retinopathy and diabetic nephropathy. Don't worry, we will discuss about all the complications in this video only. Now, ophthalmological findings. This patient's ophthalmological examination reveals microaneurysm, retinal hemorrhages, and heart exudates, and these are characteristic findings of diabetic retinopathy, which is a microvascular complication of diabetes mellitus, and that can lead to vision problems. Urine analysis findings. The presence of albuminuria on urine analysis is indicative of diabetic nephropathy, another microvascular complication. It is characterized by damage to the small blood vessels in the kidneys, resulting in the leakage of protein and protein into the urine. The thing that I want you to know is this is not so much uh, rocket science here, but what I want you to know is that you need to understand which one is microvascular, which one is macrovascular. Okay, I want you to understand that because the questions can just play in between which one microvascular complications that can give you macrovascular complications in the options too. So you need to know which one is microvascular, which one is macrovascular. Okay, that we will learn in this video. But before that, we will also do one more question. So which of the following is the most likely diagnosis for his current condition? A 45-year-old man with a 10-year history of type 2 diabetes mellitus presents to the clinic with complaints of burning pain and numbness in his feet, particularly at night. He described it as pins and needles, sensation that keeps him awake. Physical examination reveals decreased sensation to light, touch, and loss of ankle reflexes. Lab studies show a hemoglobin of HbA1c of 8.5%. Which of the following is the most likely diagnosis? Now, the patient has a history of 10 years history of type 2 diabetes mellitus and is now complaining of pain and numbness in his feet. He described it as pins and needle sensation. Now, by the time you know that this is a complication of diabetic neuropathy, right? So the key findings is including the symptoms of peripheral neuropathy like burning pain, numbness, pins and needle sensations in his feet, particularly at night. These symptoms are consistent with diabetic neuropathy, which is a common complication of diabetes. Now there are some sensory changes like physical examination may reveal decreased sensation to the light touch and loss of ankle reflexes, both of which are characteristic of peripheral neuropathy. The diabetic neuropathy often presents with sensory disturbances and decreased reflexes. Now, the elevated HbA1c proves that the patient blood glucose level is not in the target level. So the patient has poorly controlled blood glucose levels, which are a risk factor for the development and progression to diabetic neuropathy. Now let's talk about the complications of diabetes mellitus. So macrovascular complications, the main problem is accelerated atherosclerosis, which puts patient at increased risk of stroke, MI, and CHF. Okay, now we are jumping into the macrovascular complication. The main problem is atherosclerosis, which is predisposing the patient to stroke, MI, and congestive heart failure. And this accelerated atherosclerosis in diabetics is the reason the target BP is lower in diabetics, 130 upon 80, than in in general population, that is 140 upon 90. And the reason the target LDL is lower in the diabetics, that is less than 100 milligram per deciliter. Now, in addition, the process of fibrinolysis may be impaired in diabetic patients, again predisposing them to the stroke and MI. Now, the manifestations of atherosclerosis include coronary artery disease, peripheral vascular disease, and cerebrovascular diseases. So the risk of coronary artery disease is 2 to 4 times higher, and the most common cause of death in the patient is the silent myocardial infarctions, which is due to the microvascular complication or accelerated atherosclerosis. The peripheral vascular diseases are only present in the 60% of the diabetic patient, and a few of them also experience strokes. Now, this is just a summary. We will have a lot of images and tables like this in the future slides. So the patient may have if you can just remember this figure, then that will be so easy for you. The patient may experience a stroke. The patient may experience diabetic retinopathy, cataracts due to the increased glucose deposition and all, and the patient can also has glaucoma. Also, in the heart, the patient may have silent MI, which is the most common cause of death. The gastroparesis due to the diabetic neuropathy, there is the delayed emptying of the of the stomach, which will lead to the decrease in the um, diet of the patient. And the patient can also have nephropathy, okay, which we will be discussing in later. The patient has also impotence, which is due to the again diabetic neuropathy. The patient have peripheral vascular diseases due to the diabetic vascular complications, and the patient has neuropathy, and this neuropathy will lead to the loss of sensation in the legs, and the patient will have injury which the patient will be unaware about, and that can lead to diabetic foot. Now let's talk about the microvascular complications. Now the most important cause is the diabetic neuropathy, which is the most important cause of end-stage renal disease in the US. Now there are pathological types like nodular glomerular sclerosis, in which you can see the Kemmelston-Wilson nodules, which is due to the hyaline deposition in one area of glomerulus, which is pathognomic for diabetes mellitus. The diffuse glomerular sclerosis is the hyaline deposition, is global. Okay, so if there is deposition or the glomerular sclerosis in nodules only, then that is the nodular glomerular sclerosis. If there is diffuse, then all the parts of the nephrons will be involved. Now, the microalbuminuria and proteinuria, it is one of the most important parameter, so that strict glycemic control can be maintained. The diet blood glucose has been shown to limit the progression from microalbuminuria to the clinical proteinuria. So without effective treatment, the albuminuria gradually worsens. Hypertension usually develops during the transition between the macroalbuminuria and progressive proteinuria. The persistent hypertension and proteinuria cause a decrease in the glomerular filtration rate, leading to the renal insufficiency and eventually end-stage renal disease. Remember, initially the GFR is elevated. Okay, initially the GFR is elevated, which is due to the hyperglycemia. And when there is the diabetic nephropathy thing happening, then the GFR will decrease, leading to the renal failure thing. So we need to control the BP aggressively. We need to initiate the ACE inhibitors or angiotensin receptor blockers immediately. Macroalbuminuria is the screening test. Okay, now this is one of the important concept, that what thing you need to check in this patient, what thing you need to monitor in this patient. The answer is microalbuminuria. So if you wait for the dipstick to be positive for the protein, you have waited too long. Remember that microalbuminuria means levels of albumin are between 30 and 300 milligram per 24 hours. But the dipstick of the urine becomes stress positive at 300 milligram of protein per 24 hours. So when the threshold of microalbuminuria ends, then the threshold for the urine dipstick starts. Okay. So microalbuminuria, we need to monitor, we need to screen in every visit of the patient. It usually takes 1 to 5 years for microalbuminuria to advance to full-blown proteinuria. However, with proper treatment, that is ACE inhibitors to control the BP, this can be prolonged. Now, once the diabetic nephropathy has progressed to the stage of proteinuria or early renal failure, glycemic control does not significantly influence its course. So ACE inhibitors and dietary restriction of protein are recommended in such cases. Now let's talk about another complication, that is the diabetic retinopathy. So it has very high prevalence of 75%, and almost after 20 years of diabetes, almost 75% of the patients will get diabetic retinopathy. Background is the non-proliferative retinopathy accounts for the majority of the cases, and fundus examination may show hemorrhages, exudates, microaneurysms, and venous uh, dilatation. We will again encounter diabetic retinopathy in our CNS lectures. Now, these patients are usually asymptomatic unless retinal edema or ischemia involves the central macula. The hypertension and fluid retention exacerbate this condition, and there is another condition which is called as a proliferative retinopathy. The key characteristics are the new vessel formation or the neovascularization. Now, initially, the background is non-proliferative. And when the neovascularization starts, then that is called as a proliferative, because there is a proliferation of the new vessels. So the two serious complications would be vitreous hemorrhage and retinal detachment, and this can lead to blindness. So the laser photocoagulation is the treatment. Let's talk about the diabetic neuropathy. So there are three neuropathies that you need to be concerned about. The first one is the peripheral neuropathy. It usually affects the sensory nerves in a stocking or glove pattern, and typically begins in feet and later involves the hand and causes numbness and paresthesia. The loss of sensation leads to the following, like ulcer formation and with subsequent ischemia of the pressure point joints, called as the Charcot joints or Charcot arthropathy. There is painful diabetic neuropathy too, in which there is hypersensitivity to the light touch, and there is severe burning pain, which is especially at night, which our patient had. The treatment of diabetic neuropathic pain is gabapentin, TCAs, and pregabalin. So the another two types of neuropathy that you need to be concerned about is the mononeuropathies and the autonomic neuropathy. So the mononeuropathies are secondary to the nerve infarction. There is median nerve neuropathy, ulnar neuropathy, and common peroneal nerve neuropathy, which is most commonly seen. The diabetic lumbosacral plexopathy causes the severe deep pain in the thigh, and there is also atrophy and weakness in the thigh and hip muscles. There is a diabetic truncal neuropathy, in which the pain is distributed in one of the intercostal nerves. And the last one is the autonomic neuropathy, in which there is the impotence in men, and also causes the neurogenic bladder, causing retention or incontinence. There is gastroparesis, which causes chronic nausea and vomiting, and oral satiety. And there is constipation and diarrhea, which is alternating, and there is postural hypotension too. So the postural hypotension is due to autonomic neuropathy. Now, this concept, even if you don't believe it, but this is the most commonly asked concept in the USMLE exam, that postural hypertension is one of the cause or one of the complications of autonomic neuropathy. Now, the other two complications are diabetic foot and increased susceptibility to the infection. Diabetic foot is caused by a combination of artery disease and nerve disease, okay, which can lead to ulcers and infections and may require amputation of the leg. Amputation is the last resort of the treatment. Now, with neuropathy, the patient does not feel pain, so repetitive injuries go unnoticed and ultimately lead to non-healing. In addition, neuropathy may mask the symptoms of peripheral vascular diseases, and also calcific medial artery disease is common, which can erroneously cause high BP readings in the lower extremities. Now, the increased susceptibility to infection, this results from the impaired WBC function, reduced blood supply, and neuropathy. The wound healing is impaired in the diabetic patients, and this can be problematic postoperatively. The diabetic patients are at increased risk of the following infections like cellulitis, candidiasis, pneumonia, osteomyelitis, and polymicrobial foot ulcer. Uh, Infections of the ischemic foot ulcers may lead to the osteomyelitis and may require amputation. Again, I repeat, amputation is only the last treatment option for diabetic foot and mouth. Now, this is the major complications of the diabetes mellitus. So in the microvascular complications, so remember microvascular, as I've told you in the beginning of the lecture, you need to know where is microvascular, where is macrovascular. So microvascular is eye, kidney, and nerves, the neuropathy, and macrovascular is in the brain, heart, and extremities. So 3 and 3. Okay, make a mnemonic, do anything you want, but do not forget this. Now, this is a very, very simple picture. Just remember this picture and you are good to go. So this I have kept only to summarize everything. So there will be macroangiopathy, cerebral vascular infarct, hemorrhage, retinopathy, cataract, and glaucoma. There will be silent myocardial infarction. There will be atherosclerosis, urinary bladder dysfunction, skin infection, gangrenous foot, peripheral neuropathy, erectile dysfunction, nephropathy, and hypertension. Now let's talk about the treatment of all these. So the macrovascular diseases, the treatment involves the reduction of the risk factors, which is daily aspirin and also the lipid lowering agents and smoking cessation. For the nephropathy, we go for the ACE inhibitors, and for the retinopathy, there is pan-retinal photocoagulation. For the neuropathy, the treatment is typically complex, so we need to address the pain and we need to address the gastroparesis because the neuropathy is a wide range of symptoms, right? So we need to address the pain by the antacids and TCAs for for the gastroparesis. Pro-motility agents such as metoclopramide can be helpful. For the diabetic foot, the best treatment is prevention, regular foot care. We can provide the patient with high arch boots and also the care of the foot wounds. Thank you for watching. Again, back in the next one with another concept. Thank you.